Good morning, everyone. Welcome to our newest edition of Treat Live here at Mount Sinai. I'm super excited to be here today with everyone and to introduce this awesome live case. We have a great case of hemorrhoid artery embolization here. We're actually filming on our West Side campus over at Mount Sinai West. Super excited about that as well. In addition to our staff here, we have a special guest today from UCLA, Dr. Jesse Stewart. Thanks for joining us, Jesse. And so without further ado, I'm going to head over to the lab, and Dr. Vibra Murthy and Dr. Sheila are here, and they're going to present the case for everybody. Thanks.
Yep, we're
Yeah, I can
here.
hear you guys great. Um, Thanks for presenting this case, Jay. So before we talk a little bit about the clinical situation, I just want to hear from you guys both what the setup is, how you started the case, the access, and where you are right now, and then we can talk about the
Okay.
clinical aspects, which I have a lot of questions.
Um, yeah, I mean, in honor of the great Aaron Fishman, I went radial. Been doing more and more of these radial. The femoral access is great, and you can really get into the IMA pretty easily, especially with the rim catheter, 65 rim, and kind of go through things pretty quickly. I saw her earlier. Um, in office hours, and I kind of went through everything with it. And she kind of expressed a preference to go radial if possible. So we scanned her, outside in the holding area, and she had an appropriately sized radial. Um, and so I have a 4 French 125 aquatempo catheter here that we use to select the IMA. Admittedly, getting into the IMA from radial, I always have to spend a little bit more time than from the groin. So, pick what you're comfortable with. Um, but she had a
Jesse,
CT
what do
scan
you
from
use
something.
typically for access? Are you using radial or femoral or both?
I do both. Yeah, and I do both kind of depending on the patient. We've had a few like octogenarians come through, so I tend to go
Yeah.
femoral for them. But yeah, I've used both. I think both are great. So yeah.
And when you do radial, is there a specific catheter that you like to use?
I've been using the one like a 110 TIG, like something in the
Yeah,
110 range.
yeah,
But I mean, you could use, like, Jay's, using like a 120. It's just it depends on the microcatheter. You might need a longer microcatheter to kind of reach distally, like to get more selective. So, I'd like to use the 2.4, but if you're using like a 2.0, then you could use like a, 165 length and make up for the length that way that you need without having to go in too far with your parent. So,
yeah. I
yeah.
actually
Yeah,
I
based on where
like
we
the
are
Sarah
now, it looks
radial
like
for
Jay
that.
picked the perfect
Yeah,
length there.
Sarah, yeah,
Yeah.
that's also like
Yeah.
110. So yeah, I mean, anything like that would be fine. Yeah.
So right now I have a 125 catheter and a 150 2.4 prograde through that.
Okay.
Yeah, and I share
May
your
not
concerns
be,
about
yeah, like how
as
tall
far
is
as
he?
she is like
Five,
five,
six.
six, yeah, not
Yeah,
not
so
too.
you might be okay. I mean, yeah, we'll
You
see
know,
how.
there is
I
a
mean, that's
technical
tall by
point
my
I think
standards.
that's interesting here. When you have a young patient and their aorta is very narrow, I think the vertebral shape is fine. When you have an older patient, I do think that the wider aorta, it's harder with a vert shape to get into the IMA, and so that's where I sort of find that, as Jesse mentioned, the TIG or the Sarah would be more beneficial for that scenario. Do you guys want to show us the angiograms and show us what you've done so far?
Yeah, we're gonna have to go back. I'm not sure we're gonna be able to show the initial run. We had a little bit of a technical error as we changed things, but we can definitely show a DSA of where we are now. We selected the IMA by radial, and then Jay expertly navigated to exactly where we want to be. So he's going to show you exactly where we are now.
I'm gonna do a little hand run here, and we'll try to get the original IMA run up at some point. But
So I think it pretty well demonstrates where we are, where we just cannulated IMA, went down south to the superior rectal.
yeah,
Jay's
and you
just
can
taking away all the drama of getting there.
Yeah, we didn't want to keep you waiting. I mean, you already woke up so early to help us. So
well,
Thanks.
the so just to be clear, I did an IMA run, which we'll try to show at some point. We're just having a little technical issue, and then I selected a right-sided superior rectal artery, and I think it's a very good demonstration of the
yeah,
pathology that we're trying to treat here with the corpus cavernosum recti. And you can kind of see that draining veins, kind of consistent with the underlying pathology. This being more like on the AVM range than a true parenchymal staining pattern. So for that reason, I mean, I know there's some not controversy, but mixed opinions on whether to do particles or just coils alone. And for me, I like to do some particles just conceptually to try to get into the distal communications with possible middle rectal and inferior rectals. And I was using 5 to 7s. More recently, I've bumped it up just because I had a couple patients with pain for a couple days, and which is to be expected. But I'm thinking maybe if the particle size is a little bigger, maybe it's a little gentler. Because
This is
the
such an
patients with
interesting concept,
coils.
Jay. I
yeah.
think that the choice of embolic here, we all know that coils are sort of standard here, but the addition of particles, I think, is important, at least based on the data.
Salient.
Jesse, tell us a little
Mhm.
bit about your opinion on particles plus coils versus coils alone.
Yeah. So, I
Mhm.
mean, I do a very small amount of very dilute particles, kind of just to decrease that blush that we see in the corpus cavernosum recti. And again, we don't want them getting, anal pain, syndrome and things like that. And that has been shown. There was a study where they did stasis with only particles. And there was definitely, more pain, with that kind of volume. Now, no ulcer, no ischemia happened, but they definitely had more pain, especially with the smaller sizes. So I just do a very, very tiny amount. I'm diluting up to like 20 in the vial. So I'm talking about starting with usually zero point 0.3 or so, and then doing really a maximum in a selective branch like this of about 1 ml of those dilute particles. But I think the bigger size is fine too,
I'm
Jay.
lost for a second.
Plenty of folks will do the 7 to 9 size as well. To me, sometimes those vessels are just so tiny in that little, area of blush that I want to make sure I'm getting a little bit distal into that. But I think both of those sizes are perfectly fine. I think this is a great location here. You're right above the CCR. I don't usually coil below pelvic brim, so I think this is a great spot to give a little dash of particles and coil it.
Yeah, I think it's but the knowing where to embolize, I think it's pretty easy to embolize pretty proximally or convenient, I would say. And I have seen some of the redo cases that I've been referred of really proximal embolization. So because I've seen those, I've become a little bit more persistent with getting, as close to the pelvic brim as I can. I don't want to go too distal, but
Yeah.
yeah,
I
this
mean,
is where I spend
sometimes
my
they get
time.
pretty small, higher up, so you might not be able to.
Agitate this
But
again.
yeah, I mean, around the area that you're at right now, I think is
I'm just gonna
ideal.
agitate this again.
Looks like you're having no trouble with reaching there with your micro, so that's great. Are
That
you
was a
pretty much,
great move. He just
Yeah.
slid it down.
yeah, are you very slick? Is your parent catheter pretty much hubbed at this point? Or?
No, I still have some wiggle room.
Sure.
I have it basically in the superior rectal origin up high.
Or sorry, is your microcatheter hubbed or?
Yeah, that's hub now.
Okay. Right. So that's
You
about
know,
as you're not
the
going to
issue I
move it
find
up
sometimes,
much farther than that. So
there are
hopefully it's
particles
not
in
too
here. Where
early.
are the particles?
Yeah.
These vessels to me are more prone to spasm than any other vessel that I routinely like select and all that. So I have nitro on the table
Hmm.
ready. Fortunately, I'm not going to give it now because I feel like we don't need to.
No, you don't
And I'm
need
just
to.
going to give,
I know some folks
but
are giving nitro, but like this isn't like a prostate where we're trying to force in like a lot
I'm
of
going to give it a nice one.
particles. So unless there's a spasm, I'm not giving nitro because that's not really
You
the
you also wonder, at least I wonder when you give nitro in this vascular bed that you're going to open up, different branches and different
exactly.
collaterals,
This is
middle
not
rectal, things like that.
beneficial, beneficial physiology for us in
I have
this
a 1 cc
situation.
of
Yeah.
saline.
Yeah.
Mhm.
Do you have another one,
As
CC?
you guys are putting the particles in, you said you're going to use 7 to 9. Is that right, Jay?
Yeah, I'm only going to give 1 cc of it.
Okay, so you're going to give a small amount, and
Starting
then
with the
as you
smaller.
you guys deliver those, I'm just gonna ask Jesse another question. This location, right at very proximal to the CCR, this seems like, in my opinion, the best location. But there's a lot, as Jay was mentioning, there's lots of people that embolize much more proximal.
Yeah, we
So
do.
have you found, at least in your experience, at this location, at least putting a small coil here gives us sort of the best possible outcome and maybe decrease the potential risk of recurrence? Or do you think it really doesn't matter too
I'm just
much?
going to give 1 cc.
Yeah, I think this is a great question because these things can open up and reperfuse from other areas and things like that. And I think me personally, I want to get as selective as I can because I want to spare normal rectal perfusion as much as we can. But then other arteries can open up and go to that, can kind of reperfuse that area, which we've seen happen. They've kind of started contributing to that CCR. So, I think in general, most of us are getting as selective as we can, but, I think, a lot of people go more proximal, of course. I don't think we've really teased out in the literature which one's going to be better as far as recurrence goes or length of procedure, things like that. But yeah.
So these
7 to 9s are always a little chunky with these
Mhm.
yeah, a little chunky.
2-4
That's a
programs.
2-4 prograde, you said, right?
Yeah, yeah.
Yeah. So one of the things about this case as compared to maybe a knee or a prostate is that the microcatheter size doesn't have to be super small necessarily. I mean, you could see how distal you got this 2-4 pretty easily down to that spot. Are you ever using small catheters like 1.7, 1.9, or you don't think it's really necessary for cases like this?
I have, but
Um,
I feel like the 2.4 is great because you get really, good
is that
imaging and
saline or
of your particles
contrast?
easily. So that's what I tend to use. But yeah, I've done like, a 2.0 as well in some cases. So yeah.
It might be hard, Jay, to
It's
get the 7 to 9 through a 2.0, I would imagine, right?
That would
Yeah,
be
I'm not gonna.
yeah, you'd
That
have
could
to
be a little sticky.
really push the
Yeah.
the 5 to 7s through there, I think. But yeah.
Yeah, the issue
Yeah.
wouldn't be the coil; it would probably be the particle.
All right.
Um,
Do we have a
what do you guys
315?
want to use for coils here as you sort of think about the next step?
I personally use the soft coils from the Bolt.
Okay.
I find that they work with the like again. I just find these vessels to be very sensitive, and when I was trying the fibered ones, I was not comfortable with the placement of them at times. So I've switched to the soft coils, and I call them the J coil sometimes for this purpose. But I use for this one I use either a 2 or 3 millimeter coil. For this one, I'll use a 3 millimeter. Is this a 15 or
315.
315? We'll
315
have a
soft.
315 M bolt soft here
Work it.
that we will
Dunk in the bowl.
deploy here.
Do you think
Um,
that vessel's going to handle a 3, or do you think because I'm looking at the size of the vessel, I wonder if the 3. I mean, I know the soft coils really probably doesn't matter too much because they're gonna coil pretty easily.
Yeah,
yeah,
But
even if you
I've
get pushed back a little bit, I
yeah
mean, I don't know that that's any type of disaster in this location. I think that would be totally fine.
yeah I agree.
Yeah, I'm
What
using
coils are
two
you using, Jesse? What do you like to use?
twos or threes. Usually, I mean, like an 8 centimeter is nice. I feel like that usually takes care of it with one. But yeah, I mean, a little longer, it's not going to hurt anything here.
What
So
does
yeah, I
everybody
mean,
think about the choice of detachable versus pushable? Because a lot of we're going to be using a lot of coils in a case like this. And so how do we navigate through the cost of these higher level coils versus the number that we have to use? What do you guys think about that?
honestly, I think pushable would be fine too. I mean, at UCLA, we
yeah.
just
Yeah.
think the most expensive way we can. So, it's
Yeah.
yeah,
In terms
yeah.
of
Did you say the
pushable, what
most
type of
expensive or the
pushable?
least expensive? I didn't.
The most expensive.
I was gonna say that's
Yeah.
beautiful.
Yeah, that's really nice. That's good. It's packing well. I mean, I was thinking it might take a 2 also, Aaron, but this is packing very well with the softs. That's great.
This little turn
Yeah,
here.
this is a tremendous coil. I love the soft coil. I agree with Jay's assessment about the non-soft coils. They're great coils as well, but I don't think you necessarily need fibered in this location. I think it's really important to get a
No,
dense pack. I mean, there's really not another. I don't know of any other coil that packs this
well,
tightly, at least peripheral coil. This is really just a great result just for one coil. I don't think you need to put any more in, to be honest.
More than
no,
that.
I'm not going to put any more in.
No, I mean,
Yeah.
I mean, when I started, I would put slightly shorter coils, and then I ended up putting more. And I
Yeah.
think a lot of people had that experience. And then eventually, we just kind of get comfortable with the length that we want. Kind of like Jade just comes out of a holster. He says 315, and it landed perfectly.
Yeah.
Yeah. You guys want to talk a little bit about how many vessels you think we need to embolize in these cases? I mean, this is a great example of where we see the blush, but there's obviously other rectals that are going to feed this. And so do we base this on what the
Oh,
angiogram
interesting.
looks like after we embolize each one, or are we going to just go and do all the different rectals that we see on the angio, regardless of whether we
Uh,
see blush? What do you think about that, Jesse?
Aaron, I want to interrupt you for 1 second. See that
Yeah.
there was a little tail on that coil, and when
Yep.
I pulled the microcatheter back, it was already detached, but the tail came up a little bit.
Yeah.
I think it like these vessels sometimes are very sensitive with these coils. If that was a fibered coil, it would have come back a lot more. So that's why I would,
Oh,
if you
absolutely.
are going to use some of these coils, the soft, it's kind of like a protective mechanism to use the soft one. Because I'm going to do a run right now, and you'll see that kind of occludes.
I've
Yeah,
also seen, especially with some of the stiffer coils, you can sometimes run into a little micro perforation, and that sometimes, creates a little bit of a headache, I think, in some of these cases because you really don't want to
I think
have
that
that
looks
if,
good.
if you can
It's great.
avoid it.
Yeah. And going back to your question, I mean, going into cases, I always think about like the 3 to 6 number for vessels to treat. I don't know,
Three to
Jesse,
six,
what
okay.
your, yeah.
Yeah, I mean, I think we're usually in that range, but I do think you have to check kind of like above that little bifurcation of the superior rectal after you embolize a couple. Sometimes you'll see additional ones
Yeah.
pop up that are supplying the CCR.
Hmm.
So I think, just like checking after you do your main initial branches that you've selected for embolization is important too. So.
So
How,
I'm
how,
gonna
do,
just
how,
do
do,
a post
how
up
does
higher
everybody
for a second.
how does everybody decide when you're done? Are we looking for complete devascularization of the area, or are we going to leave some vessels open for, to
Turn over
allow
here.
perfusion of that area? I mean, what's the end point here? How do we decide?
I would say we're really looking to take away any ones that are kind of vertical and perfusing that area, near the pubic symphysis where we're seeing CCR. If there's a
Gonna get
significant
into that.
Yeah.
blush
Yeah.
associated with that, then, and it's very vertical, then I want to take care of it. But otherwise, I'm not trying to devascularize the whole area, but really those vertical areas that lead to blush. So
Right.
So on
So
this
what do you
on
think
this
about that
run, you
little
can
vessel here?
I think you might want to get it if you can. So
yeah.
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 Mhm.
So that vessel wasn't apparent on our first run.
Yep.
So
Throw
this
it
kind of
out.
shows that,
Showing itself. Yeah.
yeah, that you have to kind of keep reevaluating things and other branches will pop up. So if you just like pull out right away, you might, kick yourself in the shin there
Do you
without.
do you think this microcatheter will be able to navigate that tiny vessel, or do you think you need nitro or a smaller catheter? This is a tiny vessel. Looks like it's about a millimeter.
I mean, it may be occlusive here for sure. I think it'll go. Um,
Yeah. I
and
mean,
then it's going to deform it with the wire and the microcatheter. So I think it's worth, uh, doing a little puff, seeing where we are.
we have nitro
I
ready
think
too.
to what everybody was saying, we have to, what was that? We have an idea of what we're seeing, we're going to go in, but even after we embolize, it has to be on a minute by minute by basis as things open up, as things appear more prominent, as things kind of actively collateralize while you're doing the case.
We have 2/8 here too, right?
It looks like you got into the origin pretty easily, uh, and the catheter's tracking fine. That's a
I
tiny
mean, I
vessel,
needed
though,
a
really small.
I needed a wire. I'm not as good as Jay, but I think it was not difficult to get into.
Yeah.
You
I
know, we
would
still
think you're good there. Yeah. You could just
Yeah. The other thing we're looking for obviously is it whether you see some collaterals
Yeah.
from the middle rectals here, just so you can kind of catch that on your angio sometimes. Um, Jesse, are you doing general angios like aortograms at all to look at middle rectals when you start, or you just go straight for the superior rectal off the IMA?
I go straight to the IMA, and then I'm looking for big anastomotic
Half a
connections,
CC.
from the middle, and they'll almost always show themselves from that IMA run.
Yeah.
And sometimes if you get more selective, you'll see it better. But yeah, I mean, pretty much just focusing on the IMA and the superior rectals. So
How often are you
So,
doing secondary angios in the internal iliacs to look for the middle rectals? Does it
yeah,
happen
I would
often?
say maybe
Yeah.
20% of the time, something
Speak
like
of
that.
it.
Oh yeah.
Speak of the devil.
You see
Yeah.
that?
Mhm.
Yeah.
We
Now
do
do we?
have a
Is there
middle
any
rectal.
value? Is there any value of cannulating it retrograde through the IMA
Yeah,
circulation,
I've been
or
doing
just you
that
have to go?
actually. Yeah, when we can, if it's got like a proximal enough communication where you can retrograde get to it, then I've been doing it that way. So that's nice.
Yeah.
Yeah, I think that's what I like about the particles a little bit.
Yeah.
It's like a
So
little,
these are the particles right now.
yeah.
Yeah.
Saline.
You don't
I
need a
mean,
lot in this vessel for sure.
No.
No. So
yeah,
we gave
pretty
1 cc of
difficult, but
particles in the last vessel, and this one we're giving half just because it's
yeah,
smaller.
I'm practically just loading the microcatheter and then flushing it out,
Yeah.
to be honest with you.
Right now he's flushing the saline.
of course, when you're distal in some of these vessels, you can see anastomotic connections. You kind of like make them show up. But the question is it something you have to go after?
Yeah.
Yeah.
There's an operator pressure on the syringe situation. If you inject hard enough, you can
Yeah.
usually open some things up. I think it's true with a lot of things.
Yeah.
The nice thing about the particle size that you guys
100%
chose
agree.
is that it's probably less likely to cause any ischemic issue, even if it refluxes into some of these other more proximal branches, which I'm sure particles at that size would,
Yeah.
just given how small the vessel is.
Yeah. Mhm.
Yeah, you can kind of see the blush from it, that middle rectal there, right? Yeah.
So
Um,
here's a theoretical question that I would love someone to help me figure out because I don't know the answer to this. Where do you think we want, from a micron size, where do you think in an ideal scenario, where do you think we would want this embolic to end up? Do we want it to be, at the 100 micron level? I mean, assuming you didn't have to worry about ischemia,
Let's do
but
a
Look
2/8.
perfect.
Yeah.
Yeah.
do
That
you
looks
think
great. Can we have a
300 is
2/8
too
soft?
small, or do you think that's something that would be
Gonna help
reasonable
him
if
load it up and all that.
if it wasn't a particle as an example, if it was some other type of embolic?
mhm, mhm.
What do you guys think?
Like,
Yeah, I don't know. When you're getting that small, I mean, you could probably get away with it, but I'm not sure the additional
Usually
benefit
we
that it's
dunk it.
providing at that level. But yeah,
the reason I ask is because we're,
Yeah, I got you,
with
buddy.
this procedure,
Go
we've essentially taken a concept,
Hmm.
hemorrhoid artery embolization, which we know works, but we've taken equipment that's pre-existing
We flush the
particles and
semen.
coils
Yeah.
and sort of
I do.
modified the way we use them for this
Actually,
procedure.
flush
But
it
if we
again.
were going to
Oh,
start
that's
from
right. There's blood
scratch and we
back.
were going to
Fine.
say, okay, we need a different embolic
Yeah.
for this, and what I'm getting at is maybe a liquid would be better
You're headed to
for
liquid.
a situation
I
like
know
this.
this. We have this conversation, I think, about just about every procedure that we can. I think it's a matter of efficiency. I think it's a matter of, getting the best embolization that we can. And I feel like with so many procedures, we've started in that place, and we've just kind of advanced to liquid. And I think hemorrhoid at some point in the future will be in that space. Whether that liquid exists now, I'm not sure. But I definitely think we're headed that way.
I
You
think,
know, I
I
agree
mean,
with you.
we could get it like where it has like a reliable, level that it penetrates to. I think that would be fine, like at the 300 micron level or something like that, which, I know those kind of things are in development, but yeah, I mean, as of right now, the information we have on liquids is, it's going to penetrate a little bit too distally. Dr. Vidal
Yeah.
did some animal studies with onyx where he got, full thickness necrosis of the rectum using
Yep.
liquid. So,
Whoa.
I mean, I would not be, maybe one day, but yeah.
This is a
The
this is a
the
2.8,
other
by
issue
the way.
with liquids, Jesse, is that we have to do so many different vessels, and we've
Exactly.
been using
Nice.
the same
Burning
microcatheter, and
microcatheter.
so
Yeah, yeah.
if we were going to use a liquid for a
Oh,
procedure like this, I think we would need something aqueous, not DMSO or
Yes.
adhesive like glue, where we could reuse the
There's no
microcatheter readily
bifurcation there. I think
and
if you
not
get into
worry
it, you'll
Yeah.
about
be
it.
fine.
That would
okay.
be
Yeah.
key here.
Let it go and then let it flop down
Okay.
to the bigger one.
Oh, there we
Beautiful.
go.
Just like that.
Um,
Beautiful.
Beautiful.
Dan, you want to talk a little bit about what our X-ray equipment in this room? Because I'm looking at the images right now, and the coils look amazing. The runs look great.
Yeah.
This is our new Siemens Icono room over on the
This
west side,
is,
and
yeah.
we both have a lot of great case that we've done in there. What's your experience been doing hemorrhoids and knees over there?
Yeah, I mean, it's the Siemens Econo platform. It's the newest Siemens machine that we have. Like you said, we've been incredibly happy with the machine. We do a pretty high volume of knees here, but to be honest with you, I mean, it's the prostates that are difficult. Getting good image quality over a knee isn't really that impressive. When you're doing a prostate at 35 degrees over an American-sized male, that's really when your imaging is going to be impressive, and it does it with low doses, and it gets it with good image quality. The image quality here is beautiful. There's no question about it. Um, we really have no issues in terms of seeing what we need to do, and I'm rarely just increasing the dose the way I would with other commercial vendors. I just don't have to do it. I mean, you can talk about your prostate experience because, like I said, that's one of the hardest in terms of on a machine. I think a prostate is really an important test for a machine.
Just that was a
Well, yeah, and
2.8
also
coil, by the way.
that was a 2.8
Just
coil.
that was
Okay.
a
Yeah.
2.8,
Yeah, I mean, and
not a 3.
that vessel is not going to accept
Tiny.
any coil perfectly. I mean, it's so small.
Yeah.
But that's
Yeah.
So
actually
we're
a
just
great
trying to
result
bluff.
for that size coil, I
Yeah.
think.
Laying them out in this location, I think, is a totally fine way to go.
Yeah,
All
that
right.
looks
Looks
great.
Nice. That's
So
fantastic.
now we kind of see where we have to go on the other side too, right?
Yep.
So let us do that.
I like to do the run at the sort of at the bifurcation of the rectal, sort of at the top. So you
Yeah.
obviously did a great job on that side. But what I typically do is I go up to the bifurcation and just do a more aggressive run, so I can see. You can already see that there's a rectal going down there
Yeah.
that you're going to
Yep.
probably want to embolize, but there may be a
I'm
third or
yeah, I'm
fourth.
pulling back a little bit and I'll do another run up higher like you're
started
saying.
doing some power runs from right before that bifurcation through the micro too, which have been nice. So yeah.
Yeah. My original run was a power run, which I still want to show at some point, but
Through the micro.
No, we did it
So
through the base catheter. You can just see the top of the base catheter. I don't know if it's appearing on your
yeah.
screen. So we're pretty well in there.
Okay.
We're seated very, very well from radial access here.
You want to get in that
And
one?
yeah,
the nice
Um,
thing about radial access, Dan, as you guys know, is that you can put that base catheter pretty far into the IMA if you need to, particularly if it's like a vertebral
yeah.
shape or burn
Yeah.
shape that allows you to sort of drive it over the microcatheter to get a little extra purchase if you need it. You don't have to. but
Well,
Yeah,
it does have the
ours is
ability to track
pretty
pretty far.
on the small side
ours
though.
is pretty far and out of necessity because of
Yeah.
the 125 catheter with the 150 prograde. You kind of
Yeah.
have to make sure that you're
Yeah, I mean,
at
you're
enough.
not at the mercy of a reverse curve catheter that may have to, depending on what you're using, just hang out at the ostium of the vessel. Here, we're essentially right above this SRA bifurcation with our base catheter. So
Yeah.
we have really good stability here.
Yeah, that's why I mentioned before I like the 110. I think Jesse mentioned that too, right? Because if you have the 110, you don't have to worry so much
Yeah.
about pushing it distally if you have that option. But in the young patient, it's not an issue at all. Sometimes it's important in an older patient with a little more tortuosity, and it becomes challenging. Hey Jesse, what are your thoughts on the different grades of hemorrhoids and the classification system and how well they respond to embolization in general? Have you seen a difference?
I think the really most important thing is their bleeding. The bleeding is their main complaint because I mean you can have some pretty significant bleeding and even with grade one. So I think surgeons. We spoke with a surgeon at Gust recently about this, and they don't really think about the grades so much as far as like yeah, it's nice to know, but I will say the data isn't really as robust for grade four. They just have more severe disease, fixed prolapse, So for those patients, it's a little bit less clear, whether they're going to get as much benefit just because they do have much more severe disease and fixed prolapse that is not going to really be addressed with this procedure. But I think there's a role for it there too, depending on the patient. So.
Yeah, can you talk a little bit more about kind of your evaluation in the office? What are the hard
Yeah.
stops? Who do you think is going to be a great candidate? And you tell them, oh, this is perfect for you, or I'm
Yeah.
not sure this is really going to be right for you. The wire.
So, I mean,
Wire.
we're really looking for people with bleeding predominant
Right.
symptoms. Often they've maybe, they may have failed some conservative interventions or in-office procedures. They may not be interested in them, or they may be needing to kind of potentially consider a surgery, but not, be interested in that. Or not be great candidates for that. So we kind of talk through that. Usually it's around we use the French bleeding score. Usually it's around like a score of like 4 or above, where we're really talking about significant bleeding symptoms.
Mm-hmm.
Scoring system isn't perfect. There's some variability there, but we're not looking for a little bit on wiping once a month. We want something a little bit more substantial that's affecting their life. Before we're even talking about this. And yeah, I want, them to have at least some point in the last, year, preferably to have had at least an anoscopy to, visualize, the hemorrhoids, see that that is in fact the cause of the bleeding. If they're having pain as a primary symptom, I really do want to make sure that they've been evaluated for things like an anal fissure, because traditionally bleeding internal hemorrhoids are not supposed to cause that much pain. So if that is a main focus symptom for them, then we want to make sure that a fissure isn't the actual cause here. As far as colonoscopy, I want them to be up to date on a full colonoscopy. It doesn't have to be as recent. If they have known hemorrhoids, we've seen them semi recently, but an anoscopy in the office is easy to get done, a lot easier than a full colonoscopy. So just having a colleague take a look. And there's some IRs that are starting to do anoscopy as well. I haven't really broached into that yet myself. Mainly because, we have collaborating colleagues and I think, we should take advantage of their expertise, on that. But that's certainly something that is apparently easy to learn from what I've heard. So.
Yeah, I mean, I think a lot of the people that are coming to an interventional radiologist, they've done other procedures, they've failed those other procedures. I think that's universally true in IR for a lot of things. So for you, if they've had banding, clipping, whatever it happens to be, does that impact you at all? Do you say you'll do slightly worse, slightly better? It makes no difference to you. I can tell you in my practice, it doesn't dramatically change anything.
No, it's not changing
Yeah,
anything dramatically for me. I mean, if they've just had another procedure, I might say, we should
sure.
give this a few weeks and
Yeah,
see
till we
if
get
that one
past that.
works, but
It's a nice
but otherwise,
stratification. You want to go
usually
into
by
the
the time
main
we
one
get
and
them
then down.
in,
Yeah,
Yeah,
we kind of
doesn't
know.
even have to go down even if
yeah.
you're just
I did a guy the other day that was getting sclerotherapy every 3 weeks for like years, just for like
use
trying
some
to
nitro if you want.
maintain the situation and not have it
Fire.
be, untenable. So,
Inferior than
I
inferior.
don't think that really bodes
Either,
poorly for
I mean,
anything.
we could probably,
This is looking
So it
nice.
looks like you guys are trying to navigate just a little bit further past that small tiny branch there.
yeah, we're at a little trifurcation here. We're going to get into at least the bifurcation.
Yeah.
You can
It
argue,
might be a great
kind of treat
spot
both
just
of those.
distal, so you could treat both at the same time, is what I was thinking.
Yeah, yeah, that's probably the plan, is just to get, if the coils behave well, with especially with the soft one, you can get them to kind of pooch into both origins.
Yeah.
Um, more stylistic than
I think
necessary.
it's very it's I think it's really important for the audience to sort of understand how small and how difficult some of these vessels are to navigate, and you guys are really expertly navigating them with a 2-4 microcatheter, which is I think very impressive.
All Dan right now.
Well, I have to use a wire. Jay just sends the microcatheters expertly, and it magically knows unshaped microcatheters go wherever Jay wants them to do on command.
The only thing in my
Apparently,
life
Dr.
that
Vidal
listens.
doesn't use a wire either. He just sends it down. I mean, he's magical too, I guess. I'm a peasant who needs a wire, sometimes.
So
That's another
what
area I think that we're seeing a lot of improvement because, I think more and more we're getting into procedures, knee
That's
being
fair.
one of them, where we can use angled microcatheters. And this is definitely a space where there's a future where we may not need it at all. As again, Jay has expertly demonstrated. An angled microcatheter, there's a world where the right one can just take care of this whole procedure for you. That's great.
yeah,
Oh,
It's a great
it's
angio too, because we're seeing that middle rectal blush come in at the
yeah,
end.
yeah,
just
perfect.
That's
tiny one.
supply right there.
Hmm.
Cool.
So again, we'll go back to our particles. This one probably do a CC just because we are seeing some
Yeah.
compensatory flow from the middle.
And
One
you guys
CC leaves
diluted
nine
those
to 100.
particles, the 20
Yeah,
cc's or different. Wow, there's a middle rectal there too. Um,
yeah.
20. Yeah.
Yep, 20, and then we'll do a CC.
Okay.
Or
I mean, I think it could handle it. I'm usually just starting with a smaller amount, especially given the small vessel. But I mean, I don't think it's
Do
yeah.
you do aliquots?
I do. Yes.
What do you typically do?
I start with point three.
Obviously, it's
Yeah.
dependent
See
on the
how it
vessel,
looks.
but
Yeah. Usually start with point three or so because these are so tiny.
And
Yeah.
Jesse, you're using 500s, or I missed what you said before.
I'm doing 5 to 7. Yeah.
Okay, got it.
Jesse, have you
What
had
do we
any
tell patients about recurrence? So like you have a great embolization result. 4 to 5
Yeah.
vessels are embolized.
two
What
Yeah.
do we tell patients about number one, success rates, but also about recurrence rates at, let's say, a year, 2 years?
Yeah, I mean, we don't have good data out, for several years, obviously, but yeah, I'm telling them, basically all treatments for hemorrhoids have a recurrence risk, even
yeah.
Yeah.
hemorrhoidectomy. They don't treat every single column, because then they're at risk for stenosis and things like that. So everything has a risk for recurrence.
Take it
That's
on a
not
second.
the bar. But as far as like, needing another embolization procedure to get good control of their bleeding, I give them around, a 10 to 20% chance of needing a second procedure. And I usually give it about 3 months before we make the decision to do that. Dr. Vidal, he actually like, makes an agreement with his patients that your bleeding will not be completely gone. We're trying to get it to a manageable level where it's not affecting your life so much. So that's not really, no bleeding ever is not really the
That's it.
expectation.
All of us. Yeah, we're right at that bifurcation. Let's.
And you
Beautiful.
said you
Yeah.
wait 3 months before you repeat the angio and do maybe a
Yeah.
secondary embolization. Okay.
Yeah, there's some patients where, of
I'm
course,
gonna go
we
down
like
again,
to
or
see
no?
patients respond
I think we
within a
just
month
yeah.
and a lot do, but there's some patients that it
Yeah,
just
right
takes
there.
a little bit
Or that.
longer to
Right there.
completely
Ooh.
respond. So I think
Hey.
around the 3 month mark is where we're usually pulling the trigger on a second procedure if needed. Mm.
Do you see
And
that no
what
wire technique?
That
yeah,
was
we like that.
yeah.
That's impressive.
I mean, I learned it from Jay just 3 minutes ago.
Yeah. I do the 3 months as well, Jesse, where where no decisions are
Yeah,
made about any other
yeah,
treatments for 3 months. Let's see
yeah,
where the dust settles here.
yeah, absolutely.
What are you telling patients that are coming to you in pain and there's no bleeding?
I'm
I get
telling them
a lot of
this is
those.
not your procedure,
Yeah.
unfortunately. Yeah.
Yep.
Yeah.
So
Which
I'm
is
referring them for banding or, depending on their situation or to surgeons. Yeah. I mean, I have done, a couple for that early on. Their vessels are super tiny, super friable, and they might get some reduction in size or pain, but it's not as reliable. I think, because they're not going to have, I mean, to me, if they had hypertrophied vessels that we could really treat, they probably would be having a little bleeding. So,
Yeah.
Yeah, I've had patients that have alternative symptoms, and I said basically I've had some patients that have had improvements, but that's not going to be the primary. If that
Yeah.
happens, great. It'll be a little bonus, but
Right.
you're here to
yeah,
treat
I tell
bleeding.
them it's a bonus.
Exactly.
It's
Obviously
Yeah.
some of the
bonus.
studies have shown some improvements in pain, but they all had, really bleeding symptoms as well. So, yeah.
What size
Yeah.
coil do you have here? I would assume it's a 2, but you tell us.
Yeah. Back to the 2/8 soft.
Great.
Let's
Okay.
see. And it's forming
Right.
nicely here.
Yes. Looking good.
We might place another one because we're kind of selective here.
Yeah.
Um, so we'll come back
Do you
and
want to do the same thing again? Same 2.8 or 2.6 or longer?
probably do another 2/8.
Another 2.8?
Yeah. But I'm gonna do a
Jesse,
puff
when
and
when
see.
you bring somebody back, let's say at the 3 month
Look.
mark for a second embolization, are you automatically going into the internals to look at the middle rectals in that scenario, or are you still going to go
Yeah.
and look at the IMA primarily?
Yeah. For any take back, we're going and looking at the internals and seeing if there's a
Yeah.
significant middle.
What's that for me? Thank
Are
you.
you starting off radial for those, or are you gonna go groin too for the
Oh, for
middles?
everything. I mean, yeah. So I mean, for that, I guess we'd have to think about, are you going to have to be switching out catheter
Contrast.
things? I mean, I think you can certainly go radial with a longer radial catheter, and that might solve all those issues. So I think that would be fine.
That one still. So
I've done
go back.
femoral for them too, and then catheter changes aren't such an issue either. So
My general
nice.
feeling on this, at least based on this angio,
Okay, right
it
here.
looks like
Recover this.
you said
I
you
did
guys
one.
were going to do that's all just one coil, it looks like, right? Yeah.
That
One.
was one coil. I'm gonna place another one here because
Yeah.
there's a branch coming off. Um, place another 2/8 here and see if it packs
Yeah, I mean, the
against it.
interesting thing is it coming there, or is it kind of that more superior medial
Is it
branch that's
is it the
coming off?
more
Is that what's feeding
superior?
it?
Yeah.
You'll
Yeah.
see. I'll do a better run right here. Do we have saline
You could
actually?
also
Jay's going to show
you
us.
could also take a 2.8 and cross the other branch if you wanted to. I would imagine
Yeah.
that probably
Yeah,
would be fine
that's
too.
Kind of bifurcated like we did on the patient's
Yeah.
right.
Yeah, it might
Let's
just
see.
cross it right across
see.
the
There's another
aorta
branch there,
perfectly.
kind of.
Yeah. So now
Yeah.
that one's kind of showing itself. Yeah.
You can see the middle rectal at the end there.
Mm-hmm.
Is your suspicion that this is going to be the end, or do you think there'll be more vessels?
I th My suspicion is that there'll probably be one more that popped up.
Yeah,
But we'll
that's
take a
definitely
look.
coming from the other branch.
Mm-hmm.
That's great.
The more you look, the more you find with these sometimes. It's
Yeah.
just, yeah.
But being able to see that amount of blush, even after embolizing, 3 separate vessels, is it just sort of, reemphasizes the point that this territory is just so vascularized,
It
and
is.
probably
Yeah.
It
more so
really,
than any other vascular bed that we work in, maybe minus the stomach, which makes it
yeah,
challenging, right? I mean, this is why this procedure is hard. The microcatheter
Uh,
work is not always the challenge. It's finding all these vessels that can be the hard part.
it's
that's
challenging,
great.
but it's also makes it possible, makes it safe. So, it's
Yeah.
not a
Yeah,
bad
it's the
thing.
good and the bad of the collaterals, right? It's
Yeah,
maintains some degree of perfusion, but the recurrence.
but yeah, I mean,
That
the
packed
limits
nicely.
are
That technique.
probably
Oh,
farther than we've even been pushing them really on like how much you can get away with. But of course, we don't know exactly where those limits are. Yeah.
it's gonna pull back a little bit for my post run here.
Interesting thing is the coil. Yeah, that one didn't really shift.
So, Jesse, a lot of patients watch these videos
That's
because
still
they find
painful.
them, even though these are more technically oriented, there's also a
Yeah.
lot of
Let me go
patients that
down.
like to see this just to sort
You
of
want to just drop
understand
another
what the
coil here?
procedure's like, but also,
Hmm.
what happens after the procedure. Do
Oh,
I,
wait a second
you
and see
know,
how it flows.
what does
That's
my
saline?
my arm look
Oh,
like,
oh,
and what does my groin look
You
like,
want
and
saline?
what's the post-procedure care look like? So, can you tell us a little bit about
If you
your
want.
post-procedure
huh?
protocol and
If
what
you
you
want.
send
Oh, yeah,
patients
yeah.
home on and all
We'll
of that?
wait for this point.
It's one of the great things about this procedure is that you really don't have to change much about what you're doing already. So all of
Take a
these
look.
patients should already be doing fiber supplements, things to prevent constipation, whether
Yeah.
that's a softener or laxative. So really, I just make sure that
There
they're
we go.
they're preventing constipation. Usually, they're already doing those things. And then otherwise, I don't send them home with any pain medication because usually they're not having, pain afterwards. And if they are, I want to hear about it. So yeah, really, really very straightforward. So just their standard precautions related to the peripheral access. So yeah.
Yeah. So just
Jay,
to
what
point
what
out,
what do you think? Are you sending patients home on anything
oh,
besides what Jesse
I
mentioned?
when I first started, I was doing some pain meds, just out of precaution, Colace, a little breakthrough pain meds. 'Cause a couple of people experience some pain. And I don't want them to be suffering. Like one patient said he had like pretty significant discomfort for a few days, and that was with 5 to 7. So I don't know if that was chalked up to that. So I increasing the size of the particle because of that. Um, give yeah, just good diet, some rest. No Valsalving, no power lifting, heavy lifting, things like that could maybe exacerbate some of these. Probably a little bit longer. I tell them for 3 days instead of the typical 24 hours. Um, and that one patient that did have pain, um, we did it on a Friday and he's still having pain on a Tuesday. We, brought him in. Um, we gave him a Medrol dose pack for any inflammation, and he felt better with that. I don't know if it was, placebo or not. But we also sent him to our colorectal surgery colleagues, out of abundance of precaution, because he was also insistent on seeing someone too, a little bit, like just to make sure everything was okay.
Yeah.
And no big issues, but um, since
Yeah, if
then,
it's more of
I think
like pressure or like tenesmus, those kind of
yeah,
symptoms
yeah.
afterwards, I think are a little more common. So yeah.
We actually see that
Um,
quite a bit in patients when we coil the rectal artery during prostate embolization. They get that.
Okay.
Um,
Hmm.
maybe not to the
oh,
same
wow.
degree that we would see here, but
Sure.
absolutely, it's something that you just really have to treat that symptomatically, I think. It's a
that's
great
great.
That
result,
looks good.
guys.
Beautiful.
Yeah.
Yeah. One nice thing that we, on our initial puff after we placed that second coil on the left side, you can see the very superior end of that second coil is kind of going into that other branch that was feeding.
Hmm.
Yeah.
Initially, we saw flow there, and I was mentioning whether or not we should drop another coil. We decided, and by we, I mean Jay, decided to give it 60 seconds and then immediately,
Yeah.
took care of it and nothing else was
Yeah,
necessary.
sometimes you
So
need a little time.
it's
So
really
we
nice.
we have a 5 French catheter, pretty far down. So I'm gonna remove my microcatheter here and do a hand injection through
Yeah.
that just
Just
to.
see what it's looking like now. See if anything posteriorly has popped up or anything like that.
Hey, I like having the 5 French down here for this reason, just
So
for my
I
post.
am doing CTAs on these people before, in part because we're trying to see what the utility is of that. I will say, like most of the time, though, if you're seeing a middle rectal that looks significant on the CTA, you're also seeing it from this IMA run. So I don't think we're missing like a ton. I think we've had one where we could see a big middle rectal with an associated blush that we just could not see on the IMA run. But that was one case so far. So I think most of the time you can see it.
So I'm injecting pretty hard here.
Yeah.
And on the original run, we had a very nice blush of the corpus cavernosum recti. I'm not appreciating that much. There is that left-sided branch that's coursing medial that's going down, but it doesn't look that hypertrophied,
No.
that distal, and
Oh,
I'm gonna leave that alone.
fair
This is
For
a great result. I mean, you still see great
yeah.
rectal perfusion,
Yeah.
and you just don't see that cavernosal perfusion down at the bottom.
Were you guys able to find the original run from there?
Yeah, how do we
Um, I think when we de-identified, are you able to pull up the original run on the other without?
Just want to show that pretty area of
yeah,
blush where it was dropping down.
Okay,
Yeah.
yeah, we can show that. Give us a
give us a
couple
second.
seconds
Let
and
me
we'll
just have to.
pull that up. We can actually put this maybe as a reference for comparison. Are you able to see that on the screen, the reference?
But Jesse, what do you think of this for an endpoint?
I like it. I mean, you could, if you wanted to, like interrogate that one that you're seeing coming off the left side. But I think that's why I want to see the
Yeah,
initial
yeah,
run.
yeah.
But I think you've addressed all major areas of blush here. So
Are you
What's
doing power
everybody's
runs at the
follow-up
end, or
protocol? When are you going to see this patient, Jay, to see how they're doing?
we do a phone call next week just to make sure that everything's okay. So I'll call her Monday, Tuesday, just to see how her weekend went. And then I'll see her in 2 weeks. Um,
Okay.
in person to see how things are, and then 2 weeks to a month, depending on how my phone call Monday or Tuesday goes.
Okay.
And then 1 month, 3 months, and then like as needed after that if things are improving. Up to 6 months actually. I see these up to 6 months. Yeah, and they can call and get in touch with any questions in the meantime. And so, if they do have, like, let's say they're bleeding, every week or something like that, and it starts going down a little bit and they're concerned that it's not gone, like Jesse was saying before, we'll wait till at least the 3 month mark to make the decision about a second intervention, unless obviously they're having like either worsening or change in their symptoms where we have to escalate and evaluate things earlier with like a CTA.
This is a great result, Jay. Awesome
Yeah,
job.
really.
Well, they have
Um, any last minute comments from Dan or Jay or
open the
Jesse
door.
before we're getting close to the hour mark here.
Yeah,
Really
we were going
perfect
to try to
timing.
show you that initial run.
Can you
Hang out with
close
us
that out?
for just a second. Um,
Next one.
Yeah, I mean, we talked a little bit about it with the embolics, our impulse to transition to liquid. I mean, what do you guys
Go
think
back
is
in.
going to be dramatically different? I mean,
And can you
Jesse,
take the
3 years, Aaron, 3 years from now, what are we doing that's going to be different? Or maybe nothing at all. Maybe we're doing it the same exact way other than embolic. Do you
Okay.
think something's going to
So go
change in terms of
forward. Can you
imaging,
put it on
follow-up,
onto
our
your back?
knowledge
Well,
of who's going to do
Retracted.
better or not?
Dan, if I was going to design an embolic material for this
Yeah,
specific procedure, because obviously we haven't done that yet,
Keep
but if
going
you were
more.
going to, I think
Like
we would have to understand exactly how distal we
just
want
hit
that
play.
to
yeah,
go.
Let it play.
Yeah.
So we're debating whether we use 500 or 700 or 900 or
All right, just
whatever
pause there.
size particle.
At the end.
We have to have a liquid that has the ability to get exactly where we want it to go, not too far, and also
right,
not too proximal. Um, and at the same time, and we know that coils are not going to occlude vessels as readily as a liquid. We've seen that in other vascular
100%.
territories. So I think that's an incredible blush
That's
there, by the
Yeah,
way.
this is
Um,
a beautiful classic look here. Great.
yeah,
yeah,
I don't know that I see that very often, but I guess this is a younger patient, so the circulation is excellent. Um,
Mhm.
but going back to what I was saying about the liquid, I think we would have to sort of think about where we wanted it to end up and design it that way. And there's obviously
yeah.
lots of aqueous-based materials that exist or are being studied now, but we have to, think about, maybe customizing them specifically for this procedure.
Yeah, I agree. I mean, we don't want permanent distal occlusion like that. That will not allow we need these collaterals to keep this area alive. We not want it down to the capillary level,
Sure.
with a liquid. So yeah, I would say yeah, we need to define better, what micron level we need this to stop and see if that can be reliably obtained with a liquid.
Yeah,
All right. So now
exactly.
that you've seen the pre with that nice blush, we're not
Yeah,
occlusion that
I
anymore.
think I think I think you nailed it.
Yeah, I think
This
I'm
is
gonna
an
leave.
incredible technical result, I think. Really impressive
Yeah,
work, guys.
Really nice.
there's just that one little one that's going down there, but it doesn't seem hypertrophy to me on that. And I do like leaving some normal looking vessels behind if I can,
Absolutely.
um,
We're not trying to take everything out, so I think this looks
not trying
great.
to take everything out. And I think, we don't have that blush anymore. So I think hopefully her bleeding will resolve pretty
100%.
soon.
I think she's going to do great.
Yeah. Well, all right,
Well,
guys, we're just gonna close
thank you.
up here, I think. Thanks,
Awesome
Jesse. I
work.
really appreciate it.
Work
Thanks, everybody.
time.
Jesse, thanks so much for joining us on the West Coast time, and looking forward to seeing everybody soon.
All right. Take care, guys.
All right. Thanks, everybody. Bye.
Benson?
Thanks.
Awesome.
Thanks.
Thanks.